Welcome to AJP Audio for June 2025. I'm Aaron Van Dorn. Today on the podcast, I spoke with Dr. Roy Perlis, Vice Chair of Research for the Department of Psychiatry at Mass General Bringham in Boston. Dr. Perlis and colleagues created a machine learning model to examine electronic health records in individuals who had recently given birth, designed to detect those who might develop postpartum depression. Following that, we'll again speak with Dr. Ned Kalin, Editor-in-Chief of the American Journal of Psychiatry, about the rest of the June issue. Dr. Perlis, postpartum depression is a very common condition, affecting about 15% of those who have given birth. It's also a major contributor to morbidity and mortality in those individuals, with an increased risk for self-harm and suicide, as well as negative effects in physical and mental health, as well as relations with the newborn and family. Your study created a machine learning model to examine a cohort of individuals who had delivered children between 2017 and 2022 and helped create a stratified risk assessment for postpartum depression based on electronic health records. What did you find?
Well, let me start by giving you a little bit more context, which is I think people don't always realize that what we're talking about with postpartum depression is not what people used to call baby blues, right? Where
Mm-hmm.
it's normal to see some degree of mood shifts, mood changes, sadness, irritability in the early weeks after delivery. What we're talking about are significant depressive symptoms that don't resolve quickly and can be quite distressing and quite disabling. What we wanted to do was develop models that would help us target interventions to people who might be at particularly high risk for postpartum depression, because what we know is that interventions do work. So we just need to be able to target them to the people who will benefit.
Mm-hmm.
What we found in our study was that when we incorporated facts that were derived from the electronic health record in an automated way, we could come up with substantially better predictions than chance and better predictions than when we tried just using a standard depression screening scale.
Your study used machine learning techniques, which have delivered some impressive results in imaging studies, but what makes this technique useful for screening for postpartum depression as opposed to the more, what you mentioned earlier, the more traditional clinician-focused screening measures?
Well, I guess the first thing I'd say is, we know at this point that machine learning can build strong models for prediction in a lot of domains. So while it's true that some of the early work was with imaging, I think it's probably fairer to say now that these kinds of approaches work in lots of areas of medicine. We don't think it's an either or. So it's
Mm-hmm.
not, use a screening tool or use a machine learning method. In fact, the point of this study was really to say if we combine the two, we can make better predictions than if we just use a screening measure or just use machine learning.
From your paper, it seems like some of this area, especially in validation for these kinds of screening methods, is somewhat understudied.
It's so frustrating because I think, especially in psychiatry, although in medicine in general, we've spent the past decade building risk stratification models that never actually get to the clinic.
Hmm.
So it's a little bit like that movie Groundhog Day, where we wake up, we build a model, we report how good the model is, and then the next day we wake up and we build a model again. And I think there are multiple reasons for that. One of them is it's hard to validate these models. It requires typically multiple hospitals working together, multiple investigators working together. It's also very hard to get these models into production, right? So it's not as though we come up with this tool and all of a sudden the hospital says, hey, great, we'll roll it out tomorrow. I think there's a gap, or tends to be a gap, between the people who build these kinds of models and the people who disseminate. And I think we're working on that. But that's been the real challenge, is getting things out into the real world.
So, is there stumbling block beyond the sheer aspect of validation between this? Is it a monetary thing, or is something else standing in the way of clinicians adopting these kinds of models?
I think for a long time it was validation, but I think now it really is more a question of devoting the resources in a healthcare system to build these kinds of models into our workflows,
Hmm.
right? So with so many health systems, for example, adopting Epic, as mine has, we were just trying to get up to speed with this transition into a new electronic health record system. And then if the psychiatrists come along or the OBs come along and say, hey, we want to incorporate this additional model, the response is, well, get in line.
Sure.
And in fact, that has been the response for years: get in line. But I think we're now at a point where the recognition is there that this is a clinically very important problem. The models are getting better. And I think finally there is the will to start understanding how these predictors can do in the real world. So I think we're getting there.
So you mentioned it not being an either or between these machine learning techniques and models and more traditional screening methods, but your study indicated that your model had a higher level of discrimination when it included data from the Edinburgh Postnatal Depression Scores, or EPDS. EPDS itself hasn't been widely studied as a predictive measure for postpartum depression. But when your model included EPDS data, it seemed to overperform it. So the question is, did the model overperform EPDS, or is there a beneficial synergy to having both methods?
I think that what we saw was our best performance came when we combined the two.
Hmm.
And that's good news because we've worked so hard to get depression screening to become a part of primary care. My colleagues in OB have worked so hard to be sure that the EPDS is part of their regular clinical process. And so, having invested all of this energy to screen for depression during and after pregnancy, it's good to know that these screens actually have some utility in prediction. To some extent, it's kind of obvious, right? If you have some degree of depressive symptoms, you're more likely to go on to have more depressive symptoms. But I think what our study adds is actually quantifying that, actually saying, okay, tell me how do I use it, right? How do I incorporate that in a model that also includes other things that we get for free in the electronic health record that don't take any additional work?
Is there some degree of clinician pushback from the idea that this model might be pointing them towards patients they wouldn't have otherwise suspected of being at risk for postpartum depression? There's some sort of black box aspect to it where they're saying, well, I didn't know that that person would be at risk for it?
Well, I think the notion of explainability is a really important one with AI. So, I do think from a clinician's point of view, it is fair to ask what are the things that are driving this prediction? And so, in deploying these kinds of models in real world settings, it's important to expose some of the, or at least explain some of the factors that go into the model.
Hmm.
We don't like doing things just because a computer says we need to. And we know that. We know clinician trust and, frankly, patient trust as well really depends on our making these models more interpretable. In terms of identifying people we might not otherwise have identified, I think that's really the point of deploying these kinds of tools. So, you know, in our cohort, overall, about 10% go on to have a diagnosis or an indication of postpartum depression in the high risk group that we identify. So if you screen positive, that's 30%, right? So you're about 3 times more likely if you're in that high risk group. It's not a perfect predictor, right? We don't have a crystal ball, but it at least lets us direct our resources towards people who might be more likely to develop it. And then at a minimum, we can direct resources towards closer follow up, see people sooner, monitor them more closely. But also, once you can stratify risk, you can maybe start to think about doing prevention studies, right? What could we do to make it less likely that this person is going to go on to have a postpartum depression? So, to my mind, beyond just identifying high risk people to monitor them, what we'd love to be able to do is use this to really start to understand how we prevent it or at least decrease risk.
So obviously the goal for models like this is to be able to kind of delineate between cohorts and focus your resources on people who are most at risk for developing these conditions. But what is the administrative burden for actually running models like this? Is it something that happens in the background, or does it take an extra step from clinicians and the people who are working with patients?
You really ask a critical question. It's hard to separate. You can't really talk about a model in the abstract. You have to think about where is it going to be deployed? How is it going to be deployed? When it alerts, who gets the alert? Who acts on the alert? I think traditionally there's some wariness about these kinds of models.
Hmm.
And by the way, this goes back to the dawn of electronic health records in the VA system, where they discovered that they could generate these alerts and then almost immediately realized, oh my goodness, as soon as you generate an alert, you generate liability and the need to do something with it. I think in this case, any next step with this tool is going to involve working out who gets the alerts and what they do.
Hmm.
You could imagine, for example, a care manager, a social worker who has a dashboard and looks at the dashboard and says, okay, these 3 people who are about to be discharged are high risk for postpartum depression. I'm going to reach out to them and make sure that they know how to reach me. I'm going to reach out to them and make sure that they are aware of resources if they become depressed, or that I can do some psychoeducation about depression. So I can imagine that sort of dashboard system where, as part of the discharge process, in the same way that we make sure people leave the hospital with a car seat, right? And with an understanding of how to, take care of their baby, we make sure that they leave the hospital with an awareness of what postpartum depression is and what to do if they start developing symptoms.
Your study didn't look at how or when the data your model generated could be used in practice, although we've been discussing a little bit in generalities. But are there any clinical implications to your work at present?
I think by design, we only use information that we would have before discharge.
Hmm.
So really, the implication is these are things we know before somebody goes home. So we can use that to make predictions. In terms of other clinical implications, I mean, I think the implication is we can build these models, and probably others can do better than we can in terms of, part of the motivation for publishing this is to say, this is how well we did. You should look in your health system, or you should figure out if some other scale does better, or some other questions will do better. It's to kind of hope that we can spur this kind of research more broadly, because the need is clearly there.
Sure.
I wish we had the resources to follow everyone as closely as possible after discharge, and for everyone to get these kinds of interventions, but we simply don't. So we need to be smarter about how we target our interventions. One thing I will say, one notable thing about our study, there has been really excellent past work trying to predict postpartum depression, but much of that work basically comes to the conclusion that if you've been depressed in the past, you're likely to be depressed in the future. I think we know that. I think that is useful, but it gets close to being a little circular. What we wanted to know is, in the people where you might not expect depression, who have not had a recent depression, who in that group, where we might not otherwise look or might not otherwise worry, do we need to worry about? So that was, in a sense, we were trying to fill a clinical gap. We know we have a big clinical risk marker in past depression. What other risks can we look at?
And it's interesting that your study found a slightly lower than what the usual average for postpartum depression is that you'd expect, which would be for 15%, as we said at the top, and you found about 10%. And do you think that excluding people with recent past diagnosis of depression disorders might have attributed for some of that decline?
Absolutely. So part of it is that, and part of it is that we're using electronic health records for follow up as well. So we're identifying postpartum depression in electronic health records, and unfortunately, we miss people. This is in some ways underscores what we're trying to do. We're trying to get better at detecting people at high risk for postpartum depression, so we don't miss it. So we don't have people with these symptoms who would benefit from some treatment and don't end up getting it.
The people coming in who have a recent history of depression disorders are kind of table stakes. Like already should be looking at, clinicians should already be looking at them. And then we're looking for the people who might have gone missing.
Absolutely. We know that a past depression increases someone's risk substantially for postpartum depression. What we wanted to solve was sort of the harder problem of, what about the people who haven't been depressed before, who might catch us by surprise, essentially.
What were the limitations of your study?
Well, there are lots of them. First of all, this is one large academic medical center health system, right? With two academic medical centers, multiple community hospitals, but in a single region in the United States.
Hmm.
So I think one important next step is, how well do these models work in other health systems? And we're talking with colleagues about how we can study that. So the first thing is, how well does it generalize? Frankly, even if it doesn't generalize, it works well in our health system. And increasingly, people are thinking about the idea that, instead of one model to rule them all, maybe what we really need is a model that is good in my health system or your health system. So that's one limitation. Another major limitation is we're using electronic health records. And electronic health records are messy and missing information, and not nearly as detailed as, for example, a clinical trial. So undoubtedly, we are missing people who develop postpartum depression in follow-up. And there may well be people who we identify as having postpartum depression where the diagnosis wasn't correct. So, health records are really noisy, really messy data, just like the real world in general. But the advantage is we have lots of it. So the ability to sit down and say, we're going to study 30,000 people and ask a question like this, in a tractable amount of time is the counterbalance to the messy data problem. There's messy data, but there's a ton of it, and it can let us learn things that we wouldn't otherwise.
What's next for your research?
So what's next for this work is to try to understand how it could work in clinical deployment.
Mm-hmm.
So our hope is to begin to deploy it in our health system in a way that it sort of follows along in the background. And first we just learn how often would it alert? How well does it work in just generating these alerts? And in parallel, if we deploy it clinically, how are we going to respond to it? Whose responsibility is it to look at these alerts, and what do we do about it? So I think that's really kind of a critical next step. How do we get this out into the real world? And then once we can study it in the real world, does it actually improve our outcomes? Because really that's the critical question. AI is fantastic in a lot of ways, but we still have to prove that it benefits our patients. And so beyond just getting it out in the real world, we need to show that using a model like this in a particular way improves outcomes for people with postpartum depression or people at risk for postpartum depression. So we're going to work with our colleagues in OB and our colleagues in psychiatry and think about how to do those really, I think, really important studies before you just disseminate technology all over the place. I think the other sorts of things we're looking at are what other tools could we add that would improve our predictions,
Mm-hmm.
whether that's using language models to read the notes, so getting additional information from the notes, or doing additional kinds of assessments before people leave the hospital, anything that could improve our prediction and improve our ability to sort of target resources. So I would say those are some of the next steps for us.
Well, Dr. Perlis, thank you for taking the time to speak with us today.
Absolutely. Thanks so much.
Up next, Dr. Ned Kalin. Dr. Kalin, welcome back to AJP Audio for June 2025.
It's nice to be with you, Aaron. Thank you.
This month I spoke with Dr. Perlis. Dr. Perlis and colleagues took a look at a machine learning model for individualized risk stratifications for postpartum depression.
Yeah, this is a really interesting study, and I'm sure that Dr. Perlis went into detail about this, but let me just say that it addresses a critical need. Postpartum depression is quite common,
Mm-hmm.
and when severe, can have significant impacts on not only moms, but families and babies. We'll talk a little bit later about another paper that actually gets into postpartum psychosis, which is the most severe form of psychiatric problems that occur during the postpartum period. In this case, though, looking at the more common postpartum depression, the authors basically took electronic medical record data from almost 30,000 pregnant women. And they actually, from these data, they excluded women that had a history of a mood disorder or a psychotic disorder or were taking antidepressants within 12 months of being pregnant. So they picked individuals that were pregnant, but also did not have a prior history of psychiatric problems or specifically mood disorders. And what they did is they used the data from the electronic medical record combined with machine learning and an artificial intelligence strategy to basically see if they could predict who would get depressed after giving birth among this group of individuals that were not depressed prior to getting pregnant. And what they found is that they used this machine learning model that in fact they could come up with a pretty good predictor. And they used variables including medical history of the person, that what happened during the pregnancy, the history of that, other various social and demographic factors that all got put into the mix, along with, and this is important, a depression rating scale that was given during pregnancy called the Edinburgh Postpartum Depression Scale. When that was all put in the mix, the predictive value was fairly good for this. This actually had a positive predictive value of around 30%, which means that the algorithm positively identified 30% of the individuals that met criteria for postpartum depression after giving birth. So of all those individuals that developed depression, the algorithm was accurate in 30% of them in identifying it. It's not great, but it picks up 30% of individuals that otherwise might not get picked up, or at least it gives ideas about who would be at risk prior to getting depressed. Also, it had what we consider a high negative predictive value. It was around 90%. And what that means is that 92% of individuals that did not have postpartum depression were identified accurately as if they did not have postpartum depression. So this is interesting. It's basically is a model or a tool that predicts the risk to develop postpartum depression. One of the caveats, I think, is that the Edinburgh Postpartum Depression Scale, which was given during pregnancy, was really important in this algorithm. And that is something that actually measures levels of depression. They took that out of the model and asked if the model itself would still be predictive, and it still was, but not as strong. I think this is a really nice step in the direction of predicting who's going to get depressed after giving a delivery, but it needs considerable additional work to become a stronger predictor as well.
Dr. Perlis mentioned that their study didn't look at actual clinical implications for their machine learning model. And I was just wondering, how far away from seeing these actual kind of machine learning models being utilized in psychiatric care clinically?
I mean, I think we're fairly far away from that. I think that this is not, again, it's not as strong a predictor as we'd like to see, but it's a really good start in my mind at developing a model and then thinking about other factors that could be added into this. So, I think the whole field of medicine is moving in that direction, using machine learning and artificial intelligence with large data sets to make predictions about individuals and risk for illness. But this clearly is not there yet.
As you mentioned earlier, we're continuing with postpartum mental health, and Kępińska and colleagues took a look at a Swedish registry study looking at familial risk for sisters of women who have experienced postpartum psychosis.
Postpartum psychosis is probably the most devastating illness that can occur for new mothers, with significant impacts on their babies, including in the most extreme cases where moms can do significant damage to their babies or even end up killing their babies in a very tragic ways when they become delusional and psychotic. So this is not a common problem. It's not necessarily an extension of postpartum depression. It's not just more severe depression. It's really a psychosis. What was really, I think, important about this study, and I think it's an important study, the findings are important, is that it used a huge sample to survey. It was 1.6 million women that had babies from the Swedish national registers. And what they did is ask the question whether or not there's a greater familial risk for individuals that have postpartum psychosis. So, in other words, if you have someone in the family that has had a postpartum psychosis, are you at greater risk if you're a sister of that individual to have a postpartum psychosis? And they also looked in cousins to see if the risk was greater in cousins, because when you think about heritability, we know that heritability should affect both children, sisters and brothers, and cousins at different levels because of the difference in genetic relatedness between the more closely related children versus the a little bit further related cousins. So what they found is that, not surprisingly, what we know from already many studies is that postpartum psychosis in the sample was relatively rare. Only roughly 2,500 individuals out of 1.6 million, or roughly 0.15%, developed a postpartum psychosis. When they looked at those 2,500 individuals, however, they found that roughly 50% of the individuals that had postpartum psychosis had a bipolar disorder. So probably a manic type of psychosis or a severe depression with psychotic features. And we've known for a long time that bipolar disorder is associated with postpartum psychoses. Most importantly, the relative risk of a sibling developing a postpartum psychosis, if your sister was affected, was increased by about tenfold. So if you have someone in the family, a sister who has developed postpartum psychosis, you have marked increased risk. And this is really important because it signals that we need to be very careful prospectively in working with those individuals that have a family history to make sure that either they don't develop this, or if they do develop it, we get on top of it right away. Now, what's also interesting is that there was not an increased risk found in the first cousins, okay, which you would have predicted based on heritability. What this suggests is that the familial risk that we've talked about has also important implications in relation to environmental influences that may affect the family or other factors that we're unaware of. So genetics and environment are probably important. But the take-home message here is that if you have a SIB that's had a postpartum psychosis, you need to be thinking about your increased risk and making sure that you get the appropriate mental health care to either prevent that or treat it right away if it begins to emerge.
Next, Savitz and colleagues took a look at systemic inflammation and its relation to anhedonic responses in patients with major depressive disorder.
So in this issue, we have a really great review by Dr. Andy Miller from Emory University on inflammation and depression, which I would encourage our readers to take a close look at. It basically summarizes what we know about inflammation and depression. It talks about individuals that may have a pathophysiology that's more related to inflammation who get depressed. And it also highlights how we can think about personalized medicine approaches in relation to individuals that have inflammatory processes that are underlying the depression and how anti-inflammatory interventions might be helpful. This paper actually is an experimental paper that looks at individuals that are depressed that have different levels of baseline inflammation. Some people have more inflammation, others have less. And they ask the question, if we give a challenge that activates your inflammatory system, will that have more of an impact in individuals that already have baseline levels of inflammation that are higher? And what they found was that, in fact, that was the case. And the specific symptom that was increased was anhedonia. Anhedonia is a hallmark feature of depression. Not all individuals that get depressed have anhedonia. It's usually associated with more severe depression, and it's characterized by an inability or decreased interest in having positive experiences and experiencing pleasure. More specifically, what the study looked at, or how it was done, was that they measured C-reactive protein as the inflammatory marker. So C-reactive protein is a acute responder to inflammation in our bodies. It's actually used as a risk factor for various inflammatory processes, and we know that increased levels of C-reactive protein may also be associated with greater risk, for example, to have heart attacks. What they did is they took depressed individuals, they split them into two groups, those with low C-reactive protein, those with higher C-reactive protein, and they then, in these two groups, administered lipopolysaccharide, which is a substance that turns on your immune system. Your immune system responds to that, and you have a bodily response to that. And they also gave placebo to the other half of the group. So this is what we call a 2x2 design. There were a group of low CRP, low inflammatory individuals that were depressed. They either got vehicle or placebo, or they got LPS, this inflammatory stimulator. And then we had a group of individuals with high C-reactive protein, and half of them got basically LPS, the other half got placebo.
Mm-hmm.
What the findings showed again was that in those individuals that had high C-reactive protein and got LPS, the stimulatory inflammatory responder, that they had a greater inflammatory response than the individuals with low CRP levels, and also had more anhedonia that was activated by this inflammatory challenge. So this suggests, again, that if you have higher levels of inflammation and depression, that you may be more sensitive to a whole variety of factors, including factors that turn on your immune system.
Finally, we have Wall and colleagues who looked at a new psychedelic treatment for depression versus standard treatment and their response to emotional stimuli.
Yeah, so this is a paper that is a secondary analysis of a study that was already done looking at the efficacy of psilocybin administration versus escitalopram for the treatment of depression. And in this sample, imaging data was collected. And what the investigators report in this paper are the results of the imaging data. Now, from the clinical trial, which was previously published, both treatments, 20 milligrams of escitalopram, as well as the psilocybin, which was administered at 25 milligram doses twice, both appear to be effective for treating depression. And there might have been some hints that the psilocybin was a little more effective in certain ways. However, this is looking at basically the imaging response. And the idea here is to use functional MRI to assess the brain's response to emotion activating stimuli, in this case, facial expressions, which we know activate the emotion related system in the brain. And to ask whether or not there's a differential response when people are treated with psilocybin versus the more standard SSRI, escitalopram. Now, one of the motivating factors for this study was the idea that the psychedelic treatments like psilocybin, which are thought to predominantly work through activation of the 5-HT2A receptor system, which is different than how we think about SSRIs, that they may actually have different effects. And one of the effects is that it's been known for a long time from clinical observations that SSRIs can blunt people's overall emotional sense of their affect, not just less negative affect, but sometimes less positive affect. And many patients report this sense of blunting, especially when they come off of the SSRIs. They'll say, gee, I didn't realize how everything was sort of toned down emotionally. This has not been reported with psilocybin. And what the investigators looked at was whether the brain regions that are related to emotional responding differentially responded to treatment with these two drugs. And what they found is that the individuals that received psilocybin had less blunting of these emotion-related systems than the individuals that received escitalopram. In fact, they almost found no blunting of these systems, activating these systems in the psilocybin group, and significant reductions in the ability to activate some of these emotion-related systems in individuals that were successfully treated with escitalopram. So this difference in emotional reactivity on these two drugs suggests that the psilocybin treatment may not have the same dampening down of some of the emotion-related systems more generally that may be associated with escitalopram. Now, having said that, not every patient that gets SSRIs has emotional blunting, but certainly that has been reported in some. And this may turn out to be not only an advantage for psychedelic treatments, but also we now are beginning to understand, or at least get a glimpse into, what may be happening in the brain that is differentially affecting the way patients respond in this regard.
Well, Dr. Kalin, thank you for taking the time to speak with us today.
Oh, you're very welcome. It's great to be with you, Aaron.
That's all for this month's AJP Audio, but be sure to check out the other podcasts on offer from the APA, including the Medical Mind podcast, where another episode of the Mental Health Pathfinder series talks to Dr. Bernadette Grosjean about her later-in-life diagnosis of autism and how it has reshaped her understanding of the field of psychiatry. That and more at psychiatryonline.org or wherever you get podcasts.
The views and opinions expressed in this podcast are those of the individual speakers only, and do not necessarily represent those of the American Psychiatric Association. The content of this podcast is provided for general information purposes only, and does not offer medical or any other type of professional advice. If you're having a medical emergency, please contact your local emergency response number.